My name is David Wang, and I am a PGY2 in the Emory Internal Medicine program and Primary Care track. My presentation is titled Anti-MDA5 Associated Dermatomyositis, Clinical Features and Outcomes in a Predominantly African American Case Series. A little background, anti-MDA5 dermatomyositis is associated with distinctive cutaneous manifestations and a notable risk of ILD, including a rapidly progressive variant. Initial anti-MDA5 phenotype characterizations were mostly based on East Asian cohorts. Few studies have actually examined MDA5 manifestations in non-Asian subjects. The goal of this study is to describe the clinical findings and outcomes of a predominantly Black cohort with anti-MDA5 associated ILD and RP-ILD. For methods, this is a retrospective study characterizing the clinical characteristics, lab results, additional myositis autoantibodies, and treatment outcomes in anti-MDA5 positive patients seen at Emory University. For the results, here are a few of the results I will discuss in the next table figure. So 11 of the 17 patients were African American. All 17 patients exhibited clinically amyopathic dermatomyositis. There were no significant biochemical or clinical feature differences between Blacks and non-Blacks, despite the fact that all the RP-ILD patients were Black. Average values of CPK, aldolase, ferritin did not differ significantly between the two groups. Hyperferritinemia was noted in both Black and non-Black patients. ILD was present in 15 of the 17 patients with anti-MDA5 autoantibodies, and the condition was rapidly progressive in 6 patients. All 6 patients were presented in the Black subgroup. Interestingly, the majority of patients with anti-MDA5 antibody alone without MAAs developed only ILD, but not RP-ILD. Black patients demonstrated a higher prevalence of MAAs like listed here when compared to non-Blacks. 5 of 11 Black patients had 2 or more MAAs, while only 1 out of 6 non-Black patients had a maximum of 2 MAAs. With discussion, the clinical phenotype of our cohort is similar to patients from prior anti-MDA5 studies, but there are some noticeably different outcomes. Previous studies have identified ferritin as a most significant prognostic factor in anti-MDA5 associated RP-ILD, with high levels associated with lower survival. Patients with fatal outcomes did not have higher ferritin peaks or averages than survivors in our study, challenging this previous notion noted in past studies. As previously mentioned, Black patients exhibited many of the same key phenotypic findings in other populations. However, in our cohort, one key difference was that the frequency of these manifestations, especially RP-ILD, and hence worst outcomes, manifested in Black patients. One explanation could be related to the greater number of coexistent MAAs in Black patients. One previous study cited that coexistent MAAs could be biomarkers for a more favorable prognosis in anti-MDA5 patients, but our cohort found the opposite to be true, as patients with more MAAs have worse clinical outcomes. The next step is to explore these potential phenotypic frequency variations because they might have implications for appropriate evaluation and future treatment. These are my listed references, and thank you for attending my virtual presentation.